Well, thank you all for coming, and I'd like to thank Dr. Puku and all of the staff at New Mexico Heart Institute for inviting me, and also for being here basically in New Mexico and providing a truly exceptional cardiology group that we can refer our patients to. Let's see if I can figure this out. Somebody help me out with this. Oh, there we go. So I'm going to talk about CT coronary angiography, and I picked a very bland and generic title for my talk, The Next Revolution in Cardiovascular Medicine. So as you can see here, this is just, everybody's aware that cancer and heart disease are the number 1 and 2 causes of death in the country. But what I'd like to look at is the letter C, because I was curious. The females is the red, males is the blue. The males seem to be much more clumsy because they have their leading cause of death is accidents. I'm not sure what's going on there, but of the heart disease, coronary disease is about 48% of that. So heart disease and cancer are the leading causes of mortality, 77% of total deaths. The development of a safe and inexpensive method of detecting coronary artery disease before it manifests has the potential to revolutionize medicine. So what was the first revolution in the treatment of cardiovascular disease? It happened by accident. It was the coronary angiogram, the selective injection of contrast media into the right coronary artery of a middle-aged male by Dr. Sones at the Cleveland Clinic in 1958 introduced a new era in cardiovascular medicine that was to revolutionize our understanding for the remainder of the 20th century. This is the first coronary angiogram that was ever done, and this is a picture of it. And it was done by accident. Dr. Sons was actually trying to do an aortogram and with a power injection, and the nightmare happened where the catheter slipped down into the right coronary artery, and everybody in the cath lab had to change their scrubs, and the patient flatlined but survived, and that was the beginning of it. Prior to that, the earliest patients were extremely high risk. But prior to this, and this is the first paper that described it because they thought that they had killed the guy. And prior to doing this, they felt that it was fatal, basically, to inject contrast down the coronary arteries. So nobody even tried it. So at this time in 1965, the American Journal of Cardiology was the top cardiology journal in the world. And this is what they had to say about it. It appears that in the so-called myocardial infarct or sudden heart death in the human being, most of the cases develop independently of an acute occlusion. And it is incorrect to apply the term myocardial infarct to these lesions. This was in 1965. So then it lasted till 1980, which wasn't that long ago. I was in high school. Showed that the coronary occlusion during the first few hours is poorly understood. Traditional reluctance to subject patients to early coronary angiograms has been based on the belief that it would further injure the myocardium. Then they finally started to do coronary angiograms and showed an occlusion and an acute MI. But however, the complications of cath during acute infarction, 10 to 11% had a major complication, which was fairly significant compared to today. And then in unstable angina, they showed that most were candidates. They started to show that coronary stenosis actually was. So in summary, Prior to the development of coronary angiography, we did not know that angina and myocardial infarction were caused by coronary artery stenosis and occlusion, which is pretty dramatic because it really wasn't that long ago. All modern treatment of coronary artery disease, including stenting, thrombolytic therapy, and bypass, arose from the scientific breakthrough. So what's the next revolution? The treatment of cardiovascular disease. CT scanner. So the CT was a guy named Sir Gordon Hounsfield and Alan MacLeod won the Nobel Prize in 1979 for developing the CT scanner. Now we have a trivia question. What did the Beatles rock band have to do with all of this? Does anybody know? No. Okay. The Beatles had a record label that was called EMI, a company called EMI that used money from the Beatles' commercial success to fund one of their independent researchers. His name was Godfrey Hounsfield. Okay, I'm done. No, I'm just kidding. So let's look at a CT scanner. How much does it weigh, the donut? 2,000 pounds. How fast does it go? Rotates 4 times a second. What is the spatial resolution of a modern multi-detector CT scanner? It's less than 0.5 millimeters. So if you imagine something that weighs 2,000 pounds and goes around you 4 times a second, and you can see it less than 0.5 millimeter resolution. So I get him to play this. He jumped. Let's see if it works. So, is the volume working? No. So anyway, this is why they keep the cover on the CT scanner. Because the volume's really good because the guys are going, oh my freaking God, you know, and they're just kind of backing up. So they obviously keep the cover on. So that'll probably make most people in here not ever want to get a CT scan again. So the CT works on this, as everybody knows, it takes multiple different, from every 360 degrees, you get a different image, and it combines all of these. But how do you take pictures of a moving heart? You acquire prospectively heart rate is the key for CT coronary angiography. If you got to get the heart rate down, because they're taken at 75% of the RR interval. So in diastole, and I don't have a pointer. I have a pointer, but you can see the red, that's 75% of the RR interval when the heart is relatively motionless. This just tells you how we use about 100 cc's of contrast when the machine senses in the proximal and the center. Patient preparation. Most people in this country use metoprolol tartrate, 50 milligrams the night before and 50 milligrams the morning of the scan. In my clinic and some other clinics like Hopkins, we use ivabradine, if everybody remembers that drug. Well, it comes in extremely handy for doing CT coronary angiography because it does not drop the blood pressure. Don't worry about excessive bradycardia or hypotension, especially with ivabradine. Here's a volume reconstructed cardiac CT image. It's a very pretty picture of the coronaries. I wish I had a pointer, but this I'll have to skip if I can. This is an example of a normal CT coronary angiogram. Now, when the chest pain guidelines, the new chest pain guidelines came out in 2021, CT coronary angiography is now a class 1A indication for new onset chest pain in people with normal and coronary disease. It also has other class 1A indications. It's indicated for stable chest pain or anginal equivalent thought to be of cardiac origin, unless Atrial fibrillation is present. However, some of the newer scanners can do CT coronary angiography with patients with atrial fibrillation. We still have a little trouble with doing CTs if they've had previous stents. We can do them, but we can't. And again, the new photon counting scanners can image inside the stents, but not the scanner that we have in Silver City, that's for sure. And previous bypass graft surgery, can't get their heart rate down, or if they are excessively obese. So, case number 1, this is a 62-year-old male with exertional chest pain. He's a competitive mountain biker with no significant past medical history. His ECG and exam are normal. They always are. Whoops, exercise. What did I do? What's going on over there? Hello? Okay, so I've got 9 minutes and 50 seconds. And so what would, let's see, what would, call emergency services? Call emergency services, please, somebody. Okay. It's not working. Oh, okay. Here we go. Thank you. He has an exercise treadmill study done. He declined the stress echo due to insurance conditions. He went 14 minutes on a boost protocol with no symptoms and no EKG changes. What would you do now? He thinks it might be GI related and he wants to go to a gastroenterologist. He returns to see me 2 months later and still complains of vague anterior chest pressure, no pain at rest. What now? A CT coronary angiogram, that's the correct answer for all the questions I asked from now on. This is what he had. This is in the LAD. He's got a 99% LAD stenosis. And I sent this patient to Dr. Kim. I don't know if you remember him. Oh, I sent you the pictures before. You weren't typical cath lab guy, just not impressed with anything. You know, anyway. Second case, a 77-year-old male presents to the emergency room with an episode of marked diaphoresis, arm discomfort. He's got hypertension. His workup is negative. Follow up with me. I ordered a SPECT. This is a exercise Myview. It's completely normal. The bottom is the resting. The top is the stress. They're both the same. Stress test is completely normal. No further symptoms. Returned 3 months later, and after I talked to him for a while, he admitted he had some left arm pain. What would you do? Let's see if we can get this one. All right. CT, look what he's got. He's got a 90% LAD. And the nuke, as you saw, was completely normal. It's the last time I've ordered a regular treadmill, and I rarely order nukes anymore for obvious reasons. Now, we also use it in the emergency department. Here's a case of that. A 74-year-old male presented to the ED with new onset exertional pain. He's a retired commercial airline pilot with so I'm sure that he's had multiple workups and stress tests in the past. His exam and EKG, troponins are negative. What would you do? He had a high heart score. Would you admit this guy? Would you remember what the right answer is? Okay. So he was admitted for further testing due to a high heart score and clinical suspicion. The next day he had this. And look at what his LAD looks like. Just horrendous disease. And this was the guy flying our airplane. So he was transferred up here, and he had a complex bifurcational stenting on the proximal LAD, continues to do well with no problems. So I need a pointer, but anyway, So there's kind of a pyramid. What we can look at with CT is we can obviously look at the anatomy, but now we can look at plaque, different kinds of plaque, high risk plaque. We can look at something called perivascular fat attenuation index. Of course, we don't do that in Silver City, but this is showing that this has been shown to lead to events or be predictors of events. What I'm going to talk about is the FFR that was alluded to earlier in the talk, and also give a little bit of plaque, what's going on in the modern world of CT plaque. And the modern world is not Silver City, but we do have FFR CT. We're the only place in the state actually that has it. So if you look here, I can't read. I need new glasses. I love this word. When you look at the perivascular fat attenuation index, adipogenicity. I'm going to start using that word a lot. Adipogenicity. Yes, okay. So what is fractional flow reserve? It's used during invasive coronary angiography, ICA, to determine if a stenosis is hemodynamically significant and should be fixed with a stent. Blood flow is measured proximal and distal to the stenosis, and they give adenosine to get maximal hyperemia using a pressure wire placed in the artery. A value of less than 0.8, less than or equal to 0.8 is considered significant. So guess what? We don't need to do this with a pressure wire in the cath lab anymore. So this was from 2013. Dr. Mann, who now has his own company, somehow figured out how we could calculate fractional flow reserves from static CT images. Okay, so the next 4 slides that I'm going to show you are put in just in case someone from the audience asks me how this worked, because I have no idea, but I'm going to show you. Okay, we can use the arbitrary Langren formulations. Basically, all you need to remember is the Navier-Stokes equation right here. Okay, so that's how it works. If anybody else has any questions, just refer to these slides and you can look at these and get a good idea of exactly how this works, okay? So now here's an example of a CT FFR. And you can see where it says 0.76, that's not good. It's less than 0.8. That's in the LAD. And so that's highly suggestive that there's a severe LAD stenosis. So this just shows you that using FFR-CT is now a class 2A indication in the new chest pain guidelines. So this is a great study. It's a few years old, but it compared CT, coronary angiography, fractional flow reserve, stress perfusion imaging, as well as stress PET for ischemia diagnosis. Now, if you can remember one thing from this talk, this would be the slide to remember. So I really need to get a pointer. So let's see. I bought this on Amazon, just bought this on Amazon the other day. See if I can get it to work. Okay. So you can see here, here's this is what's called an receiver operator curve. So you want to have more area under the curve, so you have better specificity and better sensitivity. So this is a straight line. So this is basically just a flip of the coin. Okay. Then you get to see this line right here. This is the nuclear test. So the area under the curve is 0.7. CT coronary angiography alone is the next one here, and the area under the curve is 0.83. Positron emission tomography stress is the next one, and that's 0.87. And then with CT and FFR, you get an area under the curve of 0.94, which is pretty astounding. You can't get much better than that. Now I'm going to switch pointers. So this is an example of, it's got to be an easier way to do this. This is an example of this. This is the circumflex. Here's the CT. You can see a significant blockage there. This is the FFR that confirms it. The FFR is 0.64. This is the angiogram that again shows it. And look at the FFR done on the cath. It's 0.53. So it's pretty darn close to 0.64. And here's the SPECT. They do these polar images, which I never look at, but you can maybe, this is the rest, this is the stress, this is the circumflex territory. You can maybe say there's a little ischemia there. This is the stress PET. Maybe there's a little ischemia, but it certainly doesn't jump out at me. So just to finish up, I'm out of time. So we got to talk about artificial intelligence, right? Okay, so the artificial intelligence plaque staging. So AI programs from various vendors can now analyze the plaque and give us a plaque score. And each vendor has a different program. So if you look at this, the plaque stages here, if you were in stage 0, these are your MACE, your outcomes, long-term risk stratification. The stage 0, you're at a very low 10-year risk. Stage 1, and it gets worse and worse and worse to stage 3. And then I'm going to find these pointers here eventually. So in the ICONIC study, greater than 75% of culprit lesions prior to myocardial infarction were non-obstructive. That's something that cardiologists never like to talk about, especially interventionalists. But this study that I just showed you above, the plaque volumes were actually a greater determinant of 10-year risk in patients with a low CADS-RAS stenosis score compared to patients with a high score, meaning the CADS-RAS score is based on stenosis severity. So those that didn't have much stenosis severity but had a high plaque volume actually had a higher risk. Plus, the patients with a high plaque burden, despite having no obstructive disease, are at relatively high risk. Last thing I want to talk about is just whether artificial intelligence is going to take over the world and we're all going to depend on the terminators. Whether they can read the CT coronary angiograms as good as quantitative coronary angiography. So what is interesting about this, and so the AI programs are pretty closely correlated, but what I found most interesting was the analysis of the discordant cases where the AI-based evaluation and this quantitative coronary angiography disagreed on the severity of the stenosis. When the AI showed a stenosis of 70% or greater, and the quantitative angiogram showed less than 70%, the invasive FFR was less than 0.8 in 67% of those cases. So it makes you wonder. I wonder if there's any other interventionists that would like to comment on that finding. I see Dr. Coons back there, but it certainly makes you wonder. And what about radiation? It's very, very low. The average radiation is less than nuclear spike is 15, and the yearly background radiation dose in the United States is 2.4. And this just gives you an example of some of the other procedures. So take-home points, coronary CTA is the most sensitive non-invasive modality, very high sensitivity. The accuracy of FFR-CT is equivalent to invasive coronary angiography. That should have an asterisk after it, but coronary CTA should be the first-line test for assessment of symptomatic patients with respect to having CAD. Thank you very much for your attention.